Good afternoon. It's a pleasure to be here, and I've quite a few slides, so I'll kind of go through them fairly rapidly. Okay, so we became independent in 1971. After a quite violent kind of separation from Pakistan. But since then, the progress that we have made in maternal, newborn, and child health has been quite unprecedented. And these have been achieved in the context of fairly difficult problems in terms of health systems being inadequate, resources being limited. We are still a very poor country. We have consistent problems with governance, and if you're keeping track of the news recently, you will understand what is happening there. Linked with political instability, and the only time we get to in the news is when we get to be hit by the next natural disasters, and there's poverty all around. But there has been improvements, and I think that's what the story is all about. Much of the gains that we've had with health outcomes have coincided with fairly rapid gains in coverage of specific interventions. And I think what I'm going to try to do is look at those over the last 40 years. Just saw this slide from John, and basically to summarize that achievement is that we are, based on the Countdown 2015 last report, we're one of 23 countries on track to achieve MDG4. And if we accept the 2013 estimate from the UN interagency group, then we have already achieved MDG4. The next DHS results are going to be available in a few weeks' time, so we'll know for sure based on direct estimates. And our rate of decline has been one of the fastest in the world. One interesting part of that change has been reducing disparities. We know that in an unrestricted environment, boys die more than girls, but in particular in South Asia, you have seen discrimination against the girl child, which reverses natural mortality risks. And you see a bit of that in the first set of bars back in the 80s and 90s. That has reversed as mortality has declined. It is reversing to what you expect to see the natural pattern. So that's a gain. With regard to selected interventions, we have had major improvements. The chart and we're comparing here with other countries in South Asia, and the one that we're looking at are it's difficult to see this in this light, but it's the blue lines is Bangladesh. Quite rapid gains in immunization. This is measles immunization on the left one, and also ORT use. And with ORT use on the right side, we are way above the other countries in the region. One aspect of this gains intervention has been that we have done much better with interventions that are delivered through community-based approaches, but less so for interventions requiring clinical services in health facilities. And this is illustrated by these two sets of graphs. On the left, it is vitamin A supplementation. Again, we have fairly high coverage, consistently high over the years compared to skilled birth attendants on the right, where we have the lowest rates compared to the other countries in the region. Even though our mortality, as we just saw from John's slides, maternal mortality has gone down quite substantially, and that's a paradox. And if you have read our paper in the Lancet, we have tried to explain why that may have happened. Okay. So in terms of looking at this, is again from the Countdown report 2 years back. Looking at a composite coverage index of 8 interventions across the continuum of care, from preconception all the way to early childhood, we are doing pretty well in terms of that index. We have the highest, the most rapid increase in coverage of those 8 interventions of the countries being tracked in the Countdown. A net result of that has been gains in under 5 mortality, and almost all causes have gone down over the years. Pneumonia, birth asphyxia, diarrhea, prematurity, infections in general, they've all gone down. And this resulted in our effort to publish in the Lancet Series, look and examine what may have explained this. And John referred to the series that came out at the end of 2013, where we examined basically what were the health service delivery strategies and the innovations in approaches to delivering interventions that may have explained this rapid increase in coverage. And we basically looked at 4 different programs: the oral rehydration program, the family planning program, the immunization program, and the TB program. In that paper, we kind of looked at innovation in the context of it being technological, it being social, it being adaptive. And basically, the way we looked at it was summarized in the first bullet, which says basically it doesn't have to be a new idea, it just has to be new to the context that we're using it in. And so what we ended up, based on the review that we had of the Bangladesh, 40 years of experience in Bangladesh, we basically concluded that 3 features distinguishes the approach to service delivery in the country. First was this willingness to experiment with an application of community-based approaches at scale. Our willingness to partner between the government and NGOs and private sector. And I have had colleagues outside Bangladesh talking to me saying that one of the good things about Bangladesh has been allowing NGOs to become almost like corporations. And there has been early adoption and scale-up of context-specific innovations and policies. So I'll go through each one of these 3 elements. First, on the experimentation with community-based approaches, and the key part of that being community health workers. There has been a large investment in community health workers, both by the government and NGOs, and you see that in the graph there. Is there a pointer here? So this is the population growth over time. This is the population growth over time. This is the investment in the government, community health workers, more or less steady with some spurts. And then there has been a very rapid increase in NGO workers. And we're just looking at BRAC workers as this one NGO. And the reason we're looking at BRAC here is, A, because it is where we have data in terms of numbers over time, and is also, it is substantially the largest NGO providing having workers on the ground. And we were one of the first countries to deploy national levels community health workers, starting from the smallpox and malaria workers in the 60s to the BRAC oral rehydration workers. And then in the 70s, we had the government family planning workers really spanning out across the country and replicating what was learned in Matlab. We experimented and adapted various cadres of community health workers that were deployed to scale, and I'll show that a bit in the next slides. And these models varied in terms of demographic characteristics of who the workers were, what were their education, how they were paid, and we almost always used paid workers. The reliance on volunteers was very minimal across this whole 40 years, and the density of the workers. And the focus was on doorstep delivery of services. Sorry, pressing the wrong button here. So this is just a summary of a few types of cadres across, going all the way back to 1979 to more recently, the most recent cadre being the community health care providers running community clinics, started off in 2010. And as you'll notice that the dominant worker were females, and this approach was using female workers to reach families and women in the house with services and information, and that's paid off quite substantially. The scale up of community health workers, we have a fairly severe shortage of health workers, much below the WHO cutoff of 2.2 per 1,000 population. In 2011-12, there were almost 200,000 community health workers, of which about 56,000 were from the government, and the remaining were from NGOs, particularly BRAC. Until recently, the community health workers and the NGOs were limited. Basically, they were limited awareness raising and mobilization and linking families to facilities. They were not very much involved in service delivery. That has changed now. And increasingly, we see NGO workers involved in service delivery. And one example of that we see is that as a source of antenatal care, they have overtaken the government community health workers in terms of the contribution. We can look at contraception as an example of what has changed over time in terms of relationship between the coverage and workers. Between 1970s and 2011, the contraceptive prevalence increased from 8% to 62%. And in the early period of this, 85% of these contraceptions contraceptive pills were distributed by the government family planning workers. And I will show why that is important in the next slide. Looking at ORS treatment of diarrhea increased from 1% in 1980s to 81% to 2011. It is one of the highest rates in the world. And as a consequence, the proportion of under 5 deaths from diarrhea has dropped nearly 1/5 from nearly 1/5 to 2% in the last verbal autopsy national survey that we have. Quite substantial changes that we see in these interventions and their impact. So, but the situation is changing, and that is changing because the social context is changing, the barriers are reduced, and there's more female autonomy and mobility, and there's less dependency on community health workers. So if you see this is the overall contraceptive prevalence rate over time, modern methods. This blue line is the contribution of government workers in that contraception, and this pink line is the pharmacist supplied contraception. And basically, in a few years back, the switch happened, that there's greater reliance on people going out and buying contraceptives rather than getting it delivered at home. But that does not take away from the contribution of the community workers in the 70s and 80s and the 90s, because that period was needed. The second element was the experimentation with partnerships for health service delivery. We don't really know why it happened in Bangladesh, why the government was so willing to give space to NGOs, unlike many other countries. And we are pleased that it happened. There was a consistent willingness to partner with NGOs and the private sector and communities and civil societies to deliver services as the population expanded. And we have basically identified 3 different broad types of partnerships. The first was complementary or collaborative, where they were working together with shared objectives with agreed roles. For example, this is what happened in the immunization program, the TB programs, as well as in the community clinics, where the collaboration was between the government and the community, with the community providing space and houses for these for the community clinics. Sometimes these partnerships were contractual, like, for example, with the government outsourcing services to NGOs like the Urban Primary Healthcare Project. Or sometimes these partnerships were informal, where the government provided basically space and support for private organizations and NGOs to deliver services. For example, the Diabetic Association of Bangladesh is a key provider of management of diabetes in the country, and is the second largest healthcare provider in the country after the government. And it has happened because the government has provided space for it to operate and also consistent support. In the immunization program, the coverage was less than 2% in the 70s and 80s, went up to 75% in the post-85 period. Right now, it is very high, almost close to 90%. And within that partnership, the government and NGOs have had defined tasks with NGOs, for example, helping with mobilization, but also with immunization in urban areas. In the tuberculosis program, there are 44 collaborating partners, all with MOUs signed with the government, where the NGOs follow government guidelines, but which allows experimentation by the NGOs, and the NGOs then reverse that by supporting the government through training. And there's increasing expansion with the business sector. For example, there's partnership with the garment industry in terms of reaching out services to the workers, the female workers who are working in the garment factories. And then we have the third element, which is ORS. John referred to that, which the ORS was a technological innovation, and it was on the cover page of the Time in a few years back. Then we have had, in terms of innovations and policy, one of the early countries to have a national drug policy in 1982. And one of the things that resulted from that is that we can now claim to have one of the widest availability of pharmaceutical products in the country, which is homegrown, and is a very large industry, and results in fairly inexpensive drugs being available. And that has been helpful. There's a downside to that, whereas, for example, antibiotics gets pushed into the system, and there's real overuse of it. But in general, we're talking about inexpensive drugs and wide availability. And I think the other biggest contribution has been with social marketing, particularly with contraceptions and ORS. On the ORS, as I said, 80% coverage with ORS, 75% of that is social marketing. In all that, this is important, and this is why we are here. And I'll finish with these few slides. There has been rapid improvement in we are still a poor country. However, we're starting to have debates about when we will become middle economy, not if, when. I think that's the debate we're having. Okay, there has been substantial gains in female literacy. It's been impressive, and I'll walk you through this slide. This is 15 to 24 years, women, males. I'm looking at this age group because that's that's a critical age group for the kind of indicators we're looking at. And as you see here, at this point, there are more female who are literacy, and we need to, I think there are concerns about what that means, and there was Hussein's presentation, the early one, about the content of that education is questionable, and it's true for Bangladesh too, but in general, we see much more greater gains among women. And you see that in this map, comparing girls on the left, 15 to 19 years, boys on the right, same age. You see a lot more green. Green is better on the left side. You don't see, there's no green here. So this is the making of a social revolution, and I'm just waiting to see what's going to happen when these boys and girls grow older, and how the power balance in the families and the social structure are going to change. We don't know what's going to happen at that point, but interesting stuff. Okay, really not as a context issue, but we have had major improvements in access to facilities. Interestingly, is more often has been with private sector. So there's been huge improvements in access to private sector facilities over this 9-year period. At this point, almost all families live within 2 hours travel to a facility. Yeah, and most of these, a bulk of these, are private sector facilities. Coming back to this, so remaining challenge. The newborn mortality is the challenge for the country in terms of child survival. Right now, it is 60% of under 5 mortality. This is ignoring the IGME estimates. And if you notice the rates of decline, it is slowing down. So it is something to worry about quite seriously. So what that means is that we have to worry about infections, which is about 38,000 deaths the last time we counted, or preterm deaths, which is directly attributable with 12,000 deaths and another 20,000 deaths, which is as an underlying cause, or asphyxia. Those are 3 big ones that we need to deal with. And at this point, the government is seriously starting to scale up intervention, but we are not there yet. And I think that's the challenge for us going forward. So to finish, this is not a summarization, but some ending remarks. We have had continuous adaptation, experimentation, and early and rapid uptake, and has been critical for widespread coverage. Although we are on track for both MDGs 4 and 5, we need to have innovations needed to sustain rates of decline. And I'll expand a bit on that. For example, if you look at maternal mortality, we may soon learn that we have achieved MDG 5 goals. However, going forward, given that we have about 1/3 of those deaths, residual deaths, is indirect obstetric causes, and given that we have nothing in the system to deal with those deaths, we see this is a serious challenge for us. How do we provide the services that will prevent those deaths? We have continuing health workforce shortages and geographic inequities, which will benefit from experimentation, incentives, and training options. So far, the government has only tried the stick, and that hasn't worked very well in that. New technologies like cell phones, and right now the last estimate that we have that almost every household has a cell phone, at least one, and new diagnostics will increase program effectiveness. And we need to start thinking about adapting and evolving the role of the community health workers. We're not saying that we don't need them anymore. We need them, but they will need to have a redefined role as change agents. And we need to have continued experimentation with partnerships for us to scale up and sustain these gains. Thank you.